This is over 25 years that I've been associated with ASAP, and I don't know if Patrice is, I think one of the first ones we started was a support group in Philadelphia above an Irish pub a long time ago. So, I know this is a very unique meeting, and I think it's one of the things, if you look at all of the people that come from all over the country here to speak, we do it out of passion and enjoyment of giving back to our patients. There's no other healthcare meeting or group that I'm aware of in all of healthcare that has a meeting that's like this, where it's for the patients, by the patients. Everything we do every year is predicated on the feedback we get. So it's really a unique thing. And I hope everyone here is taking advantage of being able to, spend time, bless you, with experts in the field to ask questions. And we learn, I think Dr. Keating mentioned, every time I come, and that was a great talk, that last talk. And it's something that we really struggle with as neurosurgeons, and having somebody like that as a colleague at our shoulder to talk things over with and to get ideas from and understand things that we don't understand or see every day really is where the difference comes down for all of you as patients. So I'm going to start here with, so today what I wanted to do was, again, go into a little different topic. And, you've all seen Chiari's, you've all seen the surgeries and, shrink, not shrink, all that. And God knows I've been at on that debate many times. But I wanted to kind of really look at something programmatically. And I would say I've been treating Chiari's for about 25 years. And the last, I would say, 5 years has been an epiphany for me of the surgery. And this may be heresy, especially with my neurosurgery colleagues. I mean, the surgery is the easiest part. And I think most of the surgeons would agree with that. The actual surgery, the technical aspect of it, what to do, shrink the tonsils, open the dura, those are different things. But the actual physical act of the surgery is the easiest part. What I would say is the most difficult part is treating the patient as a whole. It's really, really hard. And it takes an effort, and it takes, sometimes, pushing boundaries of things, bringing people together, sometimes forcing people together. So what is a Chiari center? And I think when most people hear this, they think of a center as, a billboard. This is what we do, a center of excellence. All the terms are there. And, but what should it be? I think that's a rare thing. You can go online, you can Google, you can put in Chiari Center, and pretty much every major university, you'll see that. And usually it's education on what a Chiari is. There's certainly named individuals who do a lot of this, but really, what should a Chiari Center be? And that's really what I want to focus on. So I'm just gonna. First and foremost, at entry, you perform Chiari's. And I think most patients would be surprised that depending on where you go, what hospital, and let's leave it at a hospital, depends who's on call. A lot of neurosurgeons do Chiari's. They're not experts in it. Sometimes they do 1 or 2 a year. Sometimes they do more than that. So I think the entry level is performing Chiari's. Second has resources, cognitive, pain management, physical therapy, and then has coordinated resources. And that's a big one. I think that's the cutoff. Having resources, but having coordinated resources and not just saying, oh, you have to go see a physical therapist. Well, that doesn't help when you go to physical therapy and the physical therapist doesn't even know what a Chiari is because they don't see them, right? And I'm seeing a lot of this. Exactly. So coordinated resources where you're going to go see our physical therapy team or this physical therapy team. It doesn't even have to be in your own center, but they understand there's a coordinated plan. There's a coordinated logarithm protocol. Has comprehensive coordinated resources and then does research, trials, collaborations, which I think every doctor here that you've heard from does do that and does have that. And we're going to get into that a little bit about, why we need to, start pushing these types of things because there's very, very little data on Chiari. And then if you break it down into pediatrics and adults, it gets even less because as Dr. Keating really eloquently described, they are different entities. And that, to this day, is a big debate. So why all of this for this? So what a Chiari is. It's technically 5 millimeters of cerebellar descent of the tonsils past the foramen magnum. Pretty simple, right? As a neurosurgeon or any type of surgeon, can fix that, take out the bone, whether we shrink the tonsils, I can fix that picture. Any surgeon can fix that picture. Well, it's not that easy, as we all know. So, why is there confusion? Why is there a need for a center? Why is there a need for coordinated care? Well, first of all, the definition. We could get 10 of the neurosurgeons up here and radiologists, and everybody would have a different definition of what a Chiari is. As mentioned, it's incidental, 1 to 2% of the population, 350 million people. You can do the math. There's a lot of people walking around with Chiaris. Does everyone need surgery? No. Are there lots of patients that have symptoms that are symptomatic Chiari and they don't know they have Chiaris? Yes. And I've talked to some of the patients last night who have been in that situation where they probably had it for 20 years and all the symptoms were there, but it just wasn't diagnosed. You know, and the symptoms are often very common, so it gets missed. Headaches, dizziness, dysesthesias, tingling, get an MRI of the neck, you have a pinched nerve. It's not as simple as it sounds. Now, if you have it and you're diagnosed and you look at all the symptoms and you know you're suffering from it, it seems obvious. But when you're seeing thousands and thousands of patients, you know, these are very, very common symptoms. And again, age, peds versus adults. There's a lot, they're different entities. And I can't emphasize that enough. And then treatment. Who and what treatment? What's the best treatment? When do you operate? What's the cutoff? So what constitutes a Chiari? And I want to kind of go through this. And again, this is some of the confusion. 5 millimeters in adults, 3 millimeters in pediatrics. Is that an absolute? If you don't have 5 millimeters, does that mean that you don't have symptoms and you're not going to benefit from surgery? I think we all know that's not the case, and vice versa. Syrinx. You know, the role of syrinx in Chiari as far as what constitutes, what's the cause. There are different patients, there are many patients that have syrinx without a Chiari. Where does that come into play? Cine flow, CSF flow dynamics that we just heard a really eloquent lecture on. Where does that come in? If there's blockage, there's no blockage. And then symptoms. So to add to the confusion, Chiari 0. So, you know, that really, I think, is you want to get into. We can have a whole conference with arguments over if that's even a real entity. Chiari 1.5, which is essentially brainstem herniation. Chiari syndrome versus the malformation. So, you know, the point I'm trying to make is that I think everybody in this room knows is this is not as simple as going on and looking at a very simple, you know, diagram and analysis of what a Chiari is and you know, what the causes are and what the treatments are. So symptoms, again, you know, headache, especially after coughing, laughing, sneezing, straining. We all know this. Neck pain, hearing, balance problems, muscle weakness, numbness, particularly in the hands. That's the first thing we'll focus on. Dizziness, ringing or buzzing in the ears or tinnitus. Problems with hand coordination, fine motor skills, difficulty swallowing. So you can see that that's a pretty big spectrum of things that millions and millions and millions of people suffer from every day in some form, way, shape, or form. So this was where my epiphany was, where I stood back and really learned a lot, basically from my team, the patient. So that's you, the beginning point. You have symptoms. Somebody mentions Chiari. That's the start of your journey. So you either are a surgical candidate or you're not. There's a, you know, we can go into that, but you get surgery, you meet all the criteria, successful, you feel great for a year, 2 years, well, then symptoms come back. Maybe they're new symptoms, maybe they're headaches, maybe they're the exact same symptoms that you're gradually getting again. Then what? Who takes care of you then? Who's to follow up with that? Is it the surgeon? Well, we look at MRIs and say, well, I got an MRI, everything's wide open here, so I don't really know what's causing it. Failure. Again, a whole topic of it can be a week-long conference of why do some patients undergo surgery and everything is pretty much textbook, but they either recur very quickly or they never get benefit or relief. Ends up into the same place. Who's going to take care of that patient? Then the medical management. You don't have a Chiari, but you have these constellation, all these symptoms that are clearly look textbook Chiari. Check every box, but you don't have a radiographic Chiari. You know, what's the diagnosis? Who's going to take care of you then? Now, as gatekeepers, when most physicians and healthcare providers hear Chiari, it automatically goes to neurosurgery. Most neurosurgeons are not equipped for this. They're in a system that is equipped for the surgical patient. Well, the Chiari patient, the first step is possibly surgery, but it's the syndrome, and that has to be treated holistically. So that's why, you know, the term that I like to use is Chiari care, not so much Chiari center, but Chiari care. And it's not a new concept. Let's think about this. Every hospital, from a community hospital to a large academic center, has a center for diabetes. Who's in there? A nutritionist, physical therapist, an endocrinologist, a primary care doctor, a cardiologist often. We have it for cardiac. We have it for cancer. We have it for stroke. If you look at an ALS program, an MS program, Parkinson's, dementia, those are multidisciplinary teams. And I don't think we've quite gotten there yet with Chiari and the related Chiari syndromes. This includes Syrinx. And, we're in healthcare, and particularly, I think sometimes there's this perception in the general public that, neurosurgeons are these, Elon Musk, Uber, technology, and it's actually quite the opposite. Neurosurgeons are, and I'll take all my colleagues can beat up on me. I think most would agree, but we're usually behind because we're very scientifically focused. Everything is a scientific process. Well, sometimes that takes time, and sometimes all things aren't obvious. Sometimes things are common sense, so we can get lost. So sometimes we're a little bit behind on things. So what should a Chiari, again, what did we put together? And when I say we, and I can't emphasize that enough, this was something that I really learned from, starting with listening to the patients, but also my providers. How many people in this room are under the care of a neurologist or a neurosurgeon at some point? So the vast majority. How many of you, your point of contact is an APP, a PA, a nurse practitioner, a nurse? Yeah, and that's exactly right. So that's who I started listening to, because those are, when you have a problem, that's where the process comes in, whether you know it or not. If it's not the first direct line, but that's usually where things get filtered through, and then we hear it. And I'll speak for myself. As a surgeon in the past, I'm kind of like, okay, is this something I surgically need to address? Is this something that, with the best of intentions, but having a thought process that, well, the MRI looks good and the patient's still having pain, the knee-jerk is we'll see a pain specialist. Well, all of you know that's not so easy, right? So it's this idea of going from left to right, first and foremost, mental health, listening to patients, hearing patients, holistic care. I'm the last guy in the world that I think that would have, and my colleagues and friends kind of teased me about the marijuana, but you know what? A lot of our patients we were finding from all backgrounds, all ages, were using, I had little grandmothers who were basically, smoking pot from their grandkids because they were trying to get relief of pain. And you can't ignore it. There are patients who are getting a lot of benefit, and we'll talk a little bit about that. And this organization helped us get some data so that we can move forward with that. Community outreach, peer support groups. How many of you have support group that you can easily or readily attend for in your care environment? Not one hand. That's a huge need. So again, this is where, our team came together and said, this is something, we do it for stroke. We have stroke support. We have Parkinson's support. We have all these other things. So that is part of being a center of care. And then the research. We have to advance research because we just don't have answers, because it's not a huge number. Everybody does things a little bit differently, but we need to coalesce. So this is, it's people, research, patient care, navigation, liaison. You need people. That's Haley Fitzgerald, who basically started our Chiari Center and pretty much directs the whole outpatient center. Jen Ross is a neuroscientist, PhD. She does all of our research, all of our IRBs. Anytime we want to get anything, smarter than all of us. So she brings things in. And then a neuropharmacist, somebody who's a pharmacist, who's part of the team, who can help us with the medications. All of you are on a multitude of pharmacotherapy, multiple different medications, and not just for pain and Chiari, but other things. Most docs, and I'll be the first to say, I don't have the same knowledge. When I was a resident, there were 2 or 3 meds we used, and you knew them inside and out. It's a different world. So the goals are really to listen to the patient, treat the patient, and collaborate. And I think those are 3 really key things. And that to me is the heart of what this needs to be. This is something that the team, again, put together of intake. Any patient that comes to us with a diagnosis of Chiari, this is an intake that they'll get. And look at the questions. Do you have, little interest or pleasure in doing things? Not at all, several days, feeling down, depressed, feeling tired, having little energy, poor appetite, feeling bad about yourselves. These are all things that we see in the patients. We tend to kind of shut them down. And this is very helpful for us, and it's helpful for the patient. So it's looking at the patient from a holistic standpoint, not just, how much is your pain, what on a scale of 1 to 10, what's your pain, where's your pain? And then we have the same thing for pediatrics, so this is just, which I'm going to talk a little bit about too, this transition of care. I think in the support group this morning, Haley was telling me that was a huge topic of discussion, transition of care. What happens when you're 16 years old and you get a Chiari decompression and now you're 21? Where does that transition of care go? It's, it's a difficult thing for the patient and the family. So this is an intake form that's very different for our pediatric population, either the youth or the parent themselves. And then the support group. And I mean, I have to say, I thought there'd be a couple hands, but not one hand. And so this is something that we started and we've talked about just an hour ago at our board meeting of doing this nationally and having all the doctors work together to coordinate these support groups. And I can tell you, I've been doing support groups for a really long time, particularly for stroke and vascular, and we learned a lot of things. Effective stroke support groups start with listening to the patients. And every month, we basically get feedback. What do you want to hear? What do you need? What doesn't help? And being able to have it so it's in a coordinated way where it's not one or two individuals just kind of telling everybody else about their problems. That's important, or their experiences, but kind of common themes, bringing in people. One of the biggest things we had, this was our last one that we just had July 10th, and there was an overwhelming theme of, what do we do for physical therapy? What are some exercises that I can do? Who do I go to? What do I ask for in physical therapy if I say I have a Chiari? And most of our patients said most of physical therapy centers don't even know what a Chiari is, or they're really worried about it and like, I don't know anything about it, or they start treating them like, a patient that had a knee replacement. So we brought in, one of our team members who runs one of the physical therapy centers, which is again, independent, but we work together. She knows more about Chiari than I think a lot of, neurosurgeons that don't do Chiari. And we work together. So neuropathic head pain, headache, most neurosurgeons will tell you, okay, that's one of the symptoms, but I don't treat that. Well, that's okay. I don't treat headaches, but we have to offer a comprehensive approach to that so that we can at least address it and treat what we can treat. And when it gets more complicated, get people into the right hands. So one of the things that we see, and everybody sees in the U.S., it's been a crisis that I don't have to tell anyone in this room, was opioid use and high tolerance. Opioids help. I mean, there's this idea that using opioids is like giving someone heroin. Can it be addictive? Can it be dangerous? If it's not, 100,000%. But there are patients on opioids that are lifesavers for many people, but you develop a tolerance, and then there are serious issues with addiction. We don't often address that, and sometimes even the neurologists don't address it well. And for the patients that don't know, there's a national database that every time a doctor prescribes an opioid or Schedule 5 drug, you're getting monitored, and if you go over a certain amount, they're going to come in and they're going to start questioning you and so people are almost afraid to treat this. So I think a lot of people have shut down, I think especially some of the younger generation of physicians. So the first and foremost, you need a diagnosis. And if a patient has a Chiari and they have a headache, common things being common, it's the starting point of the neurosurgeon to, is this a Chiari related headache? Is this a migraine? Because many patients with Chiaris also have migraines, differentiating those things. So we need to start looking for alternative treatments because we need to have a diagnosis, but also alternative treatments are critically important. And where these things come up, medical marijuana, acupuncture, physical therapy, different types of meditation, things like that. There was a great talk a couple of years that somebody gave on that, on doing meditation and doing biofeedback and things like that. We know that in a large subset of patients, this works. How do we know it? So you listen to the patient, you hear from the patient. So, one of the things that we thought was low-hanging fruit was the medical marijuana. So the first thing we did was we looked, and this is some of our medical students and our team, actually it was all of them, to be honest with you, started doing a systematic review and looked at what type of non-pharmacotherapeutic therapies are out there or treatment paradigms for patients with pain, and it's almost none. There's really nothing in the literature, and certainly not the peer-reviewed literature. So that was a starting point, that this is a clean slate. So, medical marijuana, you can't deny it. So we wanted to put some science to it. And this was a project that was funded through ASAP. Now, this wouldn't have happened without ASAP. That's why it's so important for why we all meet and why we do this. So it started with surveys, getting anonymous surveys. And we had 52 people. The age range was 31 to 60. 61% of them, of the patients reported using marijuana multiple times per day. 50% reported consuming less than 1 ounce per month. And we also looked at the strains. Not all strains are the same. So you can't just say, well, does medical marijuana work or not? Does CBD work or not? There's such a wide range of the strains, the doses. So we wanted to get some sense of that. And it was pretty clear as we went on and on and on. It was really indica kept coming up. It kept coming up. And multiple people who tried everything, and indica was the name. Preferred method of consumption was, the majority inhaled, edibles, were 33%, and then sublingual tinctures. And these all play a role too, because tinctures that's absorbed under the tongue, the effect is quite quick and short acting. There's this, whereas smoking and some of the edibles kind of have more of but those are important things depending on the types of pain patients are having. Effects lasted from 2 to 4 hours based on that. But here's the key thing, and here's the key take home. The majority of people got benefit. The majority of people got benefit. And if you look at this to really bring it down, weak, moderate, strong, very strong. And then we looked at very strong with unwanted side effects, almost zero unwanted side effects. Now, again, this is, a little more than 50 people. The majority of people got moderate to strong relief. Now, keep in mind, most of these people are experienced users. So there was a trial and error. These are people that kind of found that happy medium. But where this helps me, and I think helps all my colleagues, where people are doing, instead of just saying, I don't know anything about marijuana, I don't do that, we can have data that we can reference and say, okay, well, it seems like, because most patients will ask us, what do you think about it? How do I do it? What is your recommendation? Well, at least we have some basis now to say, well, this is a strain you should look for. These are the different ways that you can take it. This is the time that you should expect. But this is what really, I think, blew our socks off. These are direct quotes. These are direct quotes from the patients. Stopped all pharmaceuticals. Dropped gabapentin dose from 800 3 times a day to 600 once a day. Quit all prior meds. Decreased oxycodone by half. Off of all opioids, fentanyl patch. No longer on pain pills. Now, what we saw was a dramatic reduction in people that were using something where it helped. But the extreme cases were people just completely coming off. And gabapentin was a big one that people stopped and switched over to this. And again, this is just the strain. So fatigue, brain fog, memory loss. This is another thing that I think we tended to blow off. And having a Chiari Care Center, we know that there's something called cerebellar cognitive affective syndrome. And my cognitive neurologist, Peter Glebus, was like, yeah, what don't you understand about that? It's like the Chiari patients would clearly have this, and memory is clearly affected. Whereas I think the traditional line of thinking of, well, there's temporal lobes, that's anterior fossa, it doesn't fit. And, you then get misdiagnosis and poor communication where the patient feels like the doctors aren't listening, the healthcare people aren't listening, maybe they're crazy. So this is, this is the pathways in the cerebellum, and we now know this from functional MRI. And so one of the things that we started to do now is we're going to start cohorting patients that come in because of those screening tools. When they hit a certain level of cognitive issues, we're going to do a before and after of functional MRI before Chiari decompression and after, and then look at and correlate, not just, yeah, my memory seems to be better, but look at it from an actual neurophysiologic standpoint with functional MRI. And again, that happens with a team, cognitive neurology, neurocognitive specialists. So we have our own neuropsychologists that do all this. They understand Chiari. They know what we're looking for. And then neuroradiology. I mean, all those are critical. So treatment, how do we best determine treatment? It's a team. It takes a village. AI, and I'm gonna move along to, I don't know where we are in time, but AI and Chiari. We haven't even touched on AI. AI, we're so far behind in healthcare with AI. This is why, again, people like Elon Musk developed Neuralink. These people are like, okay, you dummies as doctors aren't taking advantage of this. I know all the things we can do, and I'm going to talk to healthcare leaders and show them what we can do and have a meeting of the minds. But this is something that we started doing. It's called Upright VR, where it's like many of you know, either your kids are seeing the Oculus goggles. Well, turns out that with those Oculus goggles, you can have different scenarios and you can have them walk without their shoes or socks on and go on spongy things, hard things, give different types of scenarios where the room's spinning. We can differentiate between central, peripheral, Meniere's disease with a really high degree of accuracy. So this can help us with diagnosis. This can help us differentiate certain things. And particularly, is something Chiari related or not? Is it central? Is it peripheral? Is there something else going on? Again, one piece. Imaging. We're doing this in our stroke world. We've partnered with a company in Israel that has facial recognition for stroke. So whereas now if somebody has a stroke in the field and EMS goes out, they're doing an exam, they're calling in, we're waiting for the patient to come in the ER. Every minute, 2 million brain cells dies during a stroke. Now they can take an iPad, go up to the patient, get facial recognition, have them speech recognition, and with a very high degree of certainty give us data of if this is a stroke that we can intervene on. And at the same time, what we can do, and we've been doing this for a long time, here's a patient from the other day who came in, had a stroke. There's a CTA looking at all the blood vessels on the left. This is what's called a CT perfusion, which shows us areas of the brain that aren't getting enough oxygen. And then I get a graph and it tells me this patient has a stroke or not a stroke. And this technology, everything that you see here, there's not a human involved at all. This is software and a CAT scan. No radiologist is involved, no doctors involved. It's AI saying this patient has a stroke and you need to intervene. So now if we took all of those things and we brought them into something like this, CineFlow, why can't we use this artificial intelligence with some of the other things to start getting some, just like the lecture you just heard, and quantify the different types of pressures, where there's pressure gradients, and help give us a logarithm of who's going to benefit from surgery. So, getting to the decision tree. Now let's talk about the patients that do need surgery. Not all patients with Chiari need surgery. Patient needs to be informed, part of the decision. Correct diagnosis of symptoms is absolutely critical. It's not a radiographic. And I will be very clear about this. And as patients, you know this better than anyone. I lecture this more to my colleagues. If we don't start making the guidelines and decisions, well, guess what? It's already happening. This is an actual guideline from Aetna, one of the big insurance companies, telling us who they'll pay for, telling you if your insurance company, if you have Aetna, will pay for your surgery. And if you don't meet these criteria, guess what? You're out of luck. Your insurance company's not going to pay. So this is a real problem. This is one of the reasons where we really need to, we need to take the lead on this. And again, it's a team. It's skull base, it's Chiari, it's vascular, it's pediatric, it's neuroradiology. That team is critically important. So the devil is, again, in the details. There's 100 different types of migraines. You have to be able to differentiate what they are, and that's why you need a team of experts in headache, but also need to drive that yourself as well for more of the straightforward, simple things. So I'm getting the seat over here from Jerry, so I'm going to move along. Oh, there you go. All right. How quickly you've turned from, didn't take them long. So I want to just use a patient as an example here. So, not all Chiaris are the same. On the left, there's, maybe 5 millimeters of descent in a very symptomatic patient. So a patient of mine on the right who's got about 18 millimeters of descent, pretty impressive, doesn't have any symptoms, was incidentally found. That patient benefited from surgery, needed surgery. That patient I see every year doesn't need a thing. So I'm just going to, 25-year-old, severe neck pain, lack of energy, debilitating headaches, worse around her period. And there's a CAT scan, 5 millimeters. By all criteria she meets, no one would criticize her having surgery. Well, if you actually, spend this time and look and think at 30,000 feet, talk to the patient, high stress job. She hasn't been sleeping well for 6 months. She's 25 years old. Neck is tender to touch, which is another big sign. She's very sore. Her MRI is like straight. Her muscles are tense. She has a history of childhood migraines with light sensitivity and loud noises, which these current headaches are. Her exam's completely normal. So what's the plan? She meets every single checkbox, but those are red flags. And at the end of the day, I saw her back in 3 months. She had diagnosis of migraines, started being treated for migraines. She had physical therapy for neck exercises. She changed her pillow, which was the biggest thing. She changed her pillow to an orthopedic pillow. All her symptoms went away. All of them went away. She could have very easily got unnecessary surgery. So you guys all know the surgery. You've seen it a million times. And I just want to finish with this. This is this paper that really, Dr. Keating, who's a very modest person, went to great lengths to get this paper done. And this is another reason why these meetings are so important. This is the first time that we have multiple centers, not one person saying, well, this is what I do. Multiple people, respected, high volume centers, adult and pediatrics, and separating them out. And this is the first landmark paper that's showing us what many of us knew, but we couldn't really prove it, is that it is different. And I'm not going to reiterate because he spoke very well and eloquently to this, but you see where the differences are. You see where the commonalities are. These are the things that we need to do. And this took a really long time to do. It's not as easy as picking up the phone and saying, hey, Susie, hey, Joe, let's just collect. It's a lot of work. It's a lot of lifting. So kudos, Bob, to you for that. So Chiari Center should be. Surgery is often the easiest part of the care. Holistic, comprehensive approach is critical. A multidisciplinary, coordinated approach is the key. And you must care for all aspects of the Chiari syndrome, not just the surgery. And I will finish with that. Thank you.